All right. Thank you for taking a moment to listen to this short lecture on Chapter 4. I will be walking you through a very high level overview of individual health behavior theories. So, it's our first exposure to some specific theories. We will come back to these theories again later on in our course, but I want you to get an introduction. I'm going to be talking through each theory, a few examples, but trying to keep it very light. So, we'll try to keep this recording brief, although this is a slightly longer PowerPoint slide presentation. You have that available as a resource, but essentially we'll be covering the theories of the health belief model, the theory of reasoned action and planned behavior, the trans-theoretical model, the precaution adoption process model, and the information motivation behavioral skills model. So we'll be talking a little bit about each of those. And again, we will come back to those as well. Your charge today, if you're listening to this video, is to consider how one or more of these theories might resonate with you, might fit with you in your lived experience. You might identify with it, you might agree with it, and what theories are a little different, and also what you could use for your team projects or even your individual theory assignment this semester. So keeping in mind that you have 2 assignments where I'm asking you to integrate theory into recommendations, and maybe it might be one of these theories. All right. So starting out with the idea that health is something that we all seek, right? He who has health has hope, and he who has hope has everything. Really interesting proverb. Last week we started to talk about, or last week and then earlier in this module, we started to talk about ecological levels. The idea that our health is impacted by biology and cognitive processes, but also by social norms and the world around us. And so the idea that we have this individual level, we have family and social group, we have a community and population level, we have all of culture and society and the world around us, and then we have that policy, the political and economic realities around us. So these are the different levels where we can implement health behavior change programs and have a positive effect. Now, in order to start building out an understanding of those levels, we have to start with the center of those concentric circles, which is the individual. An individual is a self-contained unit of behavior. There's a classic scientific definition. And so we have to think, do individuals have autonomy? Can we do each whatever we want? Complete free will? Are we limited? Or do we feel we're limited in our cognitive processes and our activities and what we do based on social structures, based on how much money we have access to, and resources and norms and culture? So we have to realize that we have to be careful not to be too hard on an individual, because there are a lot of factors that go into our health, and us trying to improve our health means that we have to, and the health of communities, we have to set community norms. We have to create access and opportunity. We have to realize that our biology may be part of the equation, and we'll talk about that. We'll talk about epigenetics in chapter 8, but our shared culture, our norms, the language we speak, there are so many things in our world that influence who we are, how we behave, and how in control we feel of that behavior. And we have to really think how we define an individual, and if we're really roots of ourselves, or if our identity is rooted in other things that can be changed and positively impacted. So before we talk theory, I just want us to be very inclusive and very positive in our understanding of what an individual is, and realize that these are individual theories today. And individual theories tend to really put the onus and the responsibility on the individual to make a change. And quite often that's true in many situations, but we also have to be real about all the other factors. We may have this concept of agency, which is made up of our ability to make decisions, have forethought, self-reflect, the capacity for us to make choices and act independently. We may have agency, however, how much agency do you have if you're working 3 jobs and you're overwhelmed and you're behind on your bills and your family needs added support and you haven't slept, right? There's things, a combination of choices that make up our lives, right? But there's things and social situations that impact how much choice you feel like you have in a moment. And so I want to be honest about that and real about that. So the first model we're going to talk about is the health belief model. And the health belief model was developed in the 1950s by a research team of social psychologists that work for the U.S. Public Health Service. And they really wanted to understand, how do we increase the likelihood of proactive health behavior changes? And how do we boost someone's confidence in making a change? And so they developed this concept of self-efficacy, which is really looking at somebody's willingness to make a change and whether or not they believe, yes, I can achieve this change and this change will give me the desired health benefit. Now you'll notice that some of these slides allude to a program in Nigeria that I had developed as an example health behavior program looking at smoking cessation programs for people living with HIV in northern Nigeria. And so you'll see there's a couple comments here about how this is an ideal theory to apply to that type of example. Now, this is a key term study sheet on this slide. It's a great resource. I've also linked you to UT Extension that has a great resource on the health behavior model and the Rural Health Information Hub. I'm going to walk through each of these in a second, but I just want you to have that here, all the definitions in one place. So when we want to change someone's behavior using the health belief model, we consider how do we increase their perceived risk? We want them to feel like, oh, something could go wrong. I need to be better. I need to take care of my health. I need to help my community and myself live healthy. So they have to believe, one, there's a high likelihood of something bad happening. And we call that perceived susceptibility. They're susceptible to something. But also, we have to believe that if that something bad happened, that it would actually be really bad. It's not just inconvenient, it's bad. It's deadly, it's hurtful, whatever. And so we call that severity, how bad it is. So with the example of HIV, if I have HIV and if I'm concerned about an HIV diagnosis, or if I have HIV, if I'm an individual living with HIV and I am smoking, my likelihood of lung cancer is high. I have to know that the likelihood of developing lung cancer is high. I'm susceptible, but also that lung cancer is serious. There's the perceived severity. So I have to know both of those things. And we can create awareness in a lot of different ways for this. We also have to show individuals that they can change their health. And this is a great example with the for smoking cessation example, because people need to know, even if I smoked the last 20 years, if I quit today, my health will get better. I can't add years onto my life. And so that's called self-efficacy, the belief that you can make a change and that change will reduce a risk of negative health effects. You can do better. You can be better physically and emotionally. Now, other elements of the health belief model include what we do as healthcare, public health professionals and healthcare providers. We can implement cues to action, triggers or events that help people change. We can get families talking about illness. We can hold events that prompt individuals to consider their health. And then we can also show them perceived benefits to help behavior change, and we can reduce their perception of barriers and risks. I know it's hard to eat healthy, it's expensive to buy perishable food, but we've got this meal plan for you, we've got this subsidy or this farmers market program, we can help you do that so that folks feel empowered. Now, this is an overview in the bottom. This is an image from the Journal of Public Health and Primary Care. And this shows that our demographic variables, our psychological characteristics all impact how susceptible we feel that we are, how we perceive severity, how we perceive whether or not we're motivated to change a behavior, and our understanding of the benefits and barriers. And we as healthcare and public health professionals can impact that cues to action at the bottom in order to spur action forward. Now, we also have to be real about contextual factors, though, because our understanding of boosting someone's confidence, self-efficacy, and giving them health knowledge and giving them social support, while all of that is wonderful, we have to be real about the fact that there are outside factors that are going to impact our willingness to change and are going to impact the sustainability of that change. If I have family members that smoke or drink and I'm trying not to do those behaviors, it can make it really, really difficult. Now, looking at the health belief model here, we've got some demographic variables, we've got some psychological characteristics again. We can impact the perceived benefits, barriers, severity, susceptibility, all of that through education, providing resources and information, eliminating barriers, and then, of course, by cueing individuals to change. All right, so now you should have a little bit of an overview. There's an example here on what those key processes are. Now, as part of the health belief model, individuals in their mind are doing a threat assessment. They're thinking, how can I live more healthy? How can I take better care of myself? And they're also doing a little bit of a cost benefit analysis. They are thinking about, is this worth changing? What are the long-term and short-term impacts? And so this is something really important to consider, is those cognitive processes of people's decision making. Now, there's a lot of different scenarios where the health belief model fits really well. I gave the example of quitting smoking earlier. Another example is the increase the likelihood of a female in a rural West African village getting tested for HIV. Does she feel susceptible? Does she feel like it's serious? Does she feel willing to get tested? Because there aren't a lot of barriers. Can we make it more convenient with transportation and access? Dietary change is one where health belief model is used a lot. Also safe sex practices, knowing that you have resources available to be safe. Another example is HPV vaccination, right? Do I feel susceptible to the human papillomavirus enough to where I want to be vaccinated? Now, the precaution adoption process model is the typical model. It's a different model that we use for a lot of vaccination related interventions, but the health belief model applies here as well. Now, I've got a couple examples on the following slides about this, the idea of how we think about the health belief model and how we formulate a hypothesis when we're thinking about, how do I get someone to change? How do I reduce their perceptions of barriers, but increase the perceptions of benefits and severity and susceptibility, right? This is something we have to think about. And then I've got my example here related to that program that I was talking about that was offering smoking cessation services in Nigeria. Now, I do want to say really quickly, I'm going to end this video and start a part 2 in a few minutes. Part 2 is going to pick up here on the theory of reasoned action in planned behavior. Part 1 is just the health belief model, but we'll move into this other theory and talk about an example. So please stay tuned. Please click the link for part 2. Thank you.